We will discuss on ABG and anion gap and delta ratio, especially metabolic acidosis, normal anion gap metabolic acidosis and high anion gap metabolic acidosis. Mainly to create some awareness, duty doctors. Basically, it is an interactive session. We will discuss for 20 minutes. This is normal acid-base status. Normally, body maintains ionic equilibrium status. So, total number of cations will be equal to total number of anions. Here, major cations are sodium and potassium. The measurable cations are routinely we measure sodium and potassium. Remaining are unmeasured cations. In the anions, major anions are chloride and bicarbonate. Remaining are unmeasurable anions. So, sodium, potassium, measurable cations, major cations. Unmeasured cations are like calcium and magnesium. Okay. In anions, major anions are chloride and bicarbonate. Unmeasured anions are like albumin, phosphate, sulfate, anionic paraproteins or immunoglobulins. So, this is normal acid-base status. Number of cations will be equal to number of anions. But unmeasurable anions are more than measurable cations. Unmeasurable anions are more than unmeasurable cation, that is anion gap. Normal anion gap is 8 to 12 milliequivalents per liter. Okay. Coming to the metabolic acidosis, in the normal gap metabolic acidosis, main mechanism is bicarbonate loss of bicarbonate. From 24, there is 50% decrease in bicarb, that will be compensated by increase in chloride ions. So, bicarb loss will be compensated by increase in chloride ions. That is through chloride bicarbonate exchange, there is various mechanisms. So, bicarb loss will be compensated by chloride gain, that is hyperchloremic acidosis state. Unmeasured anions number will be normal. So, anion gap will be normal. With the mechanism for acidosis is loss of bicarbonate. The loss of bicarbonate will be compensated by increase in chloride levels. From 24, bicarb decreases to 12. So, chloride from 104, it increases to 116. So, if the underlying mechanism is loss of bicarbonate and the loss of bicarbonate will be compensated by increasing chloride levels, then anion gap will be normal. That is normal gap metabolic acidosis. We should remember two important causes. One is diuria and second one is renal tubular acidosis. In diuria, there will be loss of bicarbonate. That loss of bicarbonate will be compensated by increase in chloride levels. Then there will be metabolic acidosis because of loss of bicarbonate. And anion gap will be normal. Normal means 8 to 12 milliequivalent per liter. Okay. Coming to elevated gap metabolic acidosis. Here, elevated gap metabolic acidosis, important causes are diabetic ketoacidosis. Elevated gap metabolic acidosis are, we discussed CULT. You remember CULT? K means ketoacidosis. KULT CULT. K means ketoacidosis. Ketoacidosis can be due to diabetes, starvation, alcohol. In diabetic ketoacidosis, ketones are accumulated. Ketones are acids, beta hydroxybutyrate, acetate, acetone, they are accumulated. They are unmeasurable anions. In lactic acidosis, lactate is accumulated. Renal failure, again unmeasurable anions, acids are accumulated. Other cause is toxins. Toxins are drugs. Unmeasurable anions are accumulated. So, in high anion gap metabolic acidosis, like in ketoacidosis, ketoacidosis can be due to diabetes, alcohol or starvation, where ketones are accumulated. Second cause is lactic acidosis, lactate is accumulated. Third cause is renal failure. Fourth, toxins are drugs. In these four conditions, unmeasurable anions, the increase in unmeasurable anions means acids are accumulated. Non-chloride acids are accumulated. So, what happens if acids are accumulated? There is accumulation of lactic acid. Lactic acid is converted into lactate hydrogen ion. That hydrogen ion combines with bicarb. So, there will be loss of bicarb. If more acids are accumulated, it means more hydrogen ions are accumulated. There is increase in accumulation of hydrogen ions, they utilize bicarbonate. So, each hydrogen ion combines with bicarbonate, there will be loss of bicarbonate. That is the mechanism. So, in high anion gap metabolic acidosis, so unmeasurable anions increase, means non-chloride acids, they get accumulated. So, when acids are accumulated, the hydrogen ions, they utilize bicarbonate. Okay, there will be loss of bicarbonate. That loss of bicarbonate is the cause for metabolic acidosis. And there will be increase in anion gap. From 12 it increases to 18, 20. So, in elevated anion gap acidosis, in lactic acidosis, lactic acid is accumulated, it is converted to lactate plus hydrogen ion. In diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketoacidosis, beta hydroxy bitrate, acetate, acetone are accumulated. Beta hydroxy bitric acid is converted into beta hydroxy bitrate and hydrogen ion. Acetoacetic acid converted into acetoacetate and hydrogen ion. Basically, hydrogen ions are accumulated. In methanol ingestion, formic acid is accumulated. It is converted into formate and hydrogen ions. Ethylene glycol ingestion, glycolic acid, glycoxylic acid, oxalic acid. Oxalic acid is converted into oxalate and hydrogen ions. That oxalate is excreted in urine, that forms urine crystal formation. In a case of high anion gap metabolic acidosis, if urine shows oxalate crystals, we should look for ethylene glycol ingestion. Likewise, in toluene inhalation, hippoic acid accumulation. In renal failure, phosphate and sulfates are accumulated. Means phosphoric acid. Phosphoric acid is converted to phosphate and hydrogen ions. Sulfuric acid is converted into sulfate and hydrogen ions. These hydrogen ions, they combine with bicarbonate. So, there will be loss of bicarbonate. That loss of bicarbonate is the cause for underlying metabolic acidosis. And accumulation of unmeasurable anions is the cause for high anion gap. So, in the first chart, coming to cations, measurable cations plus unmeasurable cations will be equal to measurable anions and unmeasurable anions. Okay? Because total number of cations equal to total number of anions. So, coming to the anion gap equation, anion gap is basically unmeasured anions minus unmeasured cations. So, we will get this anion gap. Usually we will avoid potassium, because potassium is 4 only, quantity is small, so we will avoid potassium. In the cations, we will take sodium. Sodium minus, in the anions, chloride plus bicarbonate, that gives anion gap. Normally sodium is 140, around 140, chloride 104 plus 24, 140 minus, that is 12, almost 12, 8 to 12 milliequivalents per liter. So, if albumin concentration decreases, if albumin level decreases, there will be decrease in anion gap. That if albumin is low, we have to get adjusted anion gap. Okay. So, here in the high anion gap metabolic acidosis, the mechanism is if there is accumulation of lactic acid is converted into lactate and hydrogen ion, that hydrogen ion combines with bicarbonate. Okay. So, there is 1:1:1 relationship. If you add 1 milliequivalent of acid, you will use 1 milliequivalent of bicarb, and anion gap increases by 1. That 1:1:1 will be maintained. We will take one example. The pH 7.1 means acidosis. HCO3 9 is metabolic acidosis. Okay, we will check the anion gap. Here the anion gap is sodium minus chloride plus bicarbonate. So, 135 minus 104 plus 11 is 115. 135 minus 115, 20. So, normal anion gap is up to 12, 8 to 12. So, here there is high anion gap. This is high anion gap metabolic acidosis. So, if anion gap increases from 12 to 20, there is 8 increase. If anion gap increases from 12 to 20, bicarb should decrease from 24 to 16. If it is pure metabolic acidosis, we expect bicarb around 16 bicarb, because there is increase in anion gap of 8. If anion gap increase from 12 to 20, bicarb should decrease from 24 to 16. Okay. But here, what is the bicarbonate level? What is the bicarbonate? 11. Okay. With that high anion gap, we expect bicarb to be 16. But here measured bicarb is 11. Means there is loss of bicarbonate from another source. That indicates loss of bicarbonate from another source. If patient is in shock, that gives lactic acidosis, the hypoxia, any condition causing hypoxia. That causes lactic acidosis, then that gives high anion gap lactic acidosis picture. If that patient has additional diarrhea, the diarrhea gives bicarb loss. So there is additional bicarb loss. There is some other source for extra bicarb loss. So since the lost additional bicarbonate ions, there is another metabolic acidosis process going on as well. So he also has non-anion gap metabolic acidosis. So along with high anion gap metabolic acidosis, this patient has non-anion gap metabolic acidosis also. He has lactic acidosis with high anion gap. So patient is in shock, so he has lactic acidosis with high anion gap. It means there is high anion gap metabolic acidosis. But expect if anion gap increase from 12 to 20, bicarb should decrease from 24 to 16. But here it is 11. So there is additional mechanism for bicarb loss. So what is the mechanism in normal anion gap metabolic acidosis? Bicarb loss will be compensated by increase in chloride ions. Okay. So this is a case of high anion gap metabolic acidosis plus non-anion gap metabolic acidosis. This is a mixed disorder. This is another case. pH 7.28 means acidosis, bicarb in 22. Okay, such as metabolic acidosis. Anion gap is 138 minus. What is the anion gap? 138 minus 95 plus 20, chloride plus bicarb, that is 23. So there will be increase of anion gap from 12 to 23, means 11 increase. So how much bicarb we expect? 24 to expect 13. But here bicarb is, measured bicarb is 20. Means that additional underlying cause for bicarb accumulation. Means that is additional metabolic alkalosis. So the case of high anion gap metabolic acidosis with metabolic alkalosis. The classical example is heart failure patient on diuretics. And heart failure can cause heart failure with shock can cause high anion gap metabolic acidosis. If patient is on diuretics, there will be a loss of sodium and chloride. Chloride loss will be compensated by bicarbonate. There will be more accumulation of bicarbonate because of chloride loss secondary to diuretics. So coming to compensation for metabolic acidosis, in a primary metabolic acidosis situation, if bicarb is 10, how much respiratory compensation we expect? The Winter's formula is 1.5 into bicarb plus 8. Means 10 means 15 plus 8. We expect 23. Okay. But simple formula is for metabolic acidosis and for metabolic alkalosis. Coming to respiratory compensation, the simple formula is add 15 to bicarb. In metabolic acidosis, compensation, carbon respiratory compensation is add 15 to bicarb, bicarb plus 15. Even in metabolic alkalosis, add 15 to bicarbonate. So 10 plus 15 is 25. With Winter's formula, respiratory compensation is 23. But within plus or minus 2, we can get the equation. The easiest way to remember for metabolic acidosis and for metabolic alkalosis, the formula for respiratory compensation is add 15 to bicarb. Okay. So we expect CO2 in a pure case of metabolic acidosis, we expect CO2 of 23. But if actual CO2 is 35, it means there is additional respiratory acidosis. So metabolic acidosis, patient, suppose patient is admitted with diabetes, diabetic ketoacidosis. The cause for metabolic acidosis is diabetic ketoacidosis. If that patient has respiratory acidosis, it means there must be underlying lung disorder. We should immediately take an X-ray chest. We should look for pulmonary edema, pneumonia, all conditions causing respiratory acidosis. That gives a clue. Usually we think that there is metabolic acidosis. There will be compensatory respiratory alkalosis because of hyperventilation. Then if you check CO2, if that shows respiratory acidosis, it is additional disorder, additional process, then immediately we should carefully look for a lung disease causing respiratory acidosis or any condition causing respiratory acidosis. Respiratory acidosis means hypercapnia, high CO2. High CO2 can occur with, there are 4 mechanisms. It can be a central cause and neuromuscular cause. Then decrease chest wall compliance, decrease lung wall compliance or acute airway obstruction, all can cause high CO2. Here pH 7.4, normal pH, bicarb 24, normal bicarb, PCO2 40, normal PCO2. If you look at ABG, if we focus only on pH, bicarb and CO2, we assume that ABG is normal. In that situation, we should look for anion gap. What is the anion gap? 140 minus 96 plus 24. 140 minus 96 plus 24, that is 20. The 20 anion gap. Normal anion gap is up to 12. So if there is increase in anion gap, there must be underlying metabolic acidosis process. Okay. Again, this is a case of high anion gap metabolic acidosis. So even though pH, PCO2, bicarb, all are normal, we should look for anion gap, because if anion gap is high, that indicates underlying high anion gap metabolic acidosis cause. We should check for ketones, we should check for lactate levels, okay? We should check for renal failure causes, or we should look for, if no cause is established, we should look for drugs causing metabolic acidosis, high anion gap metabolic acidosis, or toxins causing high anion gap metabolic acidosis. Okay. So coming to anion gap is 20. With 20, how much bicarb we expect? Anion gap increases from 12 to 20. There is 8 increase. How much bicarb we expect? How much bicarb loss we expect? Loss of 8 means 24 minus 8, 16. So in high anion gap metabolic acidosis, in this case, we expect bicarb to be 16. But here bicarb is 24. Okay. Mean there is additional another process of metabolic alkalosis. There is additional underlying process of bicarb accumulation. Can you tell one combination? High anion gap metabolic acidosis with metabolic alkalosis. So patient is on diuretics. Diuretics that can cause metabolic alkalosis, additional metabolic alkalosis. So 7.25 acidosis, bicarb 15. Okay. Metabolic acidosis. Anion gap 140 minus 107 plus 15, 18. Okay. The fourth step is 18. Again high anion gap metabolic acidosis. Okay. So how much bicarb we expect? Anion gap increases from 12 to 18. There is 6 increase. How much bicarb we expect? 24 minus 6, 18. Do we expect 18? Direct case of high anion gap metabolic acidosis. If there is single acid based disorder, we expect bicarb to be 18. But what is the bicarb here? 15. So there is additional process of non-anion gap metabolic acidosis. Means probably patient might be having some diarrhea, bicarb blast. Bicarb blast to another cause. Okay. Whenever ABG is required, simultaneously we should check basic metabolic panel, that is called BMP. We should look for these 7 parameters even in the blood also. So while taking ABG, simultaneously we should check for basic metabolic panel. Sodium, potassium, chloride, bicarb, and BN, creatinine, glucose. Along with ABG, we should look for these parameters in serum. This is called basic metabolic panel. So 7.32. Acidosis or alkalosis? Acidosis or alkalosis? Below 7.4, acidosis. Above 7.4, alkalosis. So here it is acidosis. Okay. Then metabolic acidosis. Why it is metabolic acidosis? Bicarb is low. Okay. Normal bicarb is 24. Normal bicarb is 24. Here bicarb is 14. So cause for acidosis is metabolic acidosis. Okay. So first step 1 is check pH. Step 2 is you should look for whether it is underlying primary process, whether it is metabolic acidosis or respiratory acidosis. So it is metabolic acidosis. Evaluate compensation. How much PCO2 we expect? 14 plus 15. 14 plus 15 means 29. So it is a simple case of metabolic acidosis. Okay. What is the anion gap? 140 minus the sodium and potassium. 140 sodium, 3.6 potassium. 116, 14 is chloride and bicarbonate. 13, 1 is urea and creatinine. 100 is glucose. Okay, 140 minus 116 plus 14. Okay, 130. 140 minus 130 is 10. So normal gap metabolic acidosis. Name one condition for normal gap metabolic acidosis. Bicarb loss. One mechanism is bicarb loss. Two important causes are diarrhea and renal tubular acidosis. These two are important causes. So diarrhea, there will be loss of bicarb, accumulation of chloride. So there is bicarb loss and chloride accumulation. Okay. Then another cause, renal tubular acidosis, especially proximal renal tubular acidosis, the type 2 RTA, proximal renal tubular acidosis, there will be loss of bicarb. Bicarb reabsorption is affected, loss of bicarb. So one mechanism is loss of bicarbonate. Second mechanism is accumulation of hydrogen ions. Okay. Distal renal tubular acidosis, type 1 distal renal tubular acidosis, there will be accumulation of hydrogen ions. Hydrogen potassium exchange mechanism is affected. Even type 4 renal tubular acidosis with aldosterone deficiency, hydrogen ions will be accumulated. But hydrogen accumulation means bicarb loss. There will be HCl addition and loss of sodium bicarbonate. Okay. So two important mechanisms for normal gap metabolic acidosis are loss of bicarbonate or in the accumulation of hydrogen ions in the renal causes. Here pH is 7.28 means acidosis. Cause for acidosis? Metabolic acidosis, low bicarb. Evaluate compensation. 12 plus 15 means we expect 27, but with interest formula, 18 plus 18, okay, 26. Almost two difference, almost appropriate compensation and within 2. So calculate anion gap. 128 minus 94 plus 12, 22. The high anion gap metabolic acidosis. What are the important causes of high anion gap metabolic acidosis? 4. CULT, KULT. Ketoacidosis, diabetes, alcohol, starvation. U, uremia. L, lactic acidosis. T, toxins. Toxins and drugs. It is 7.41. PaCO2 55. bicarb 34. So bicarb 34 metabolic alkalosis. With 34 we expect how much CO2? 34 plus 15. For metabolic acidosis and for metabolic alkalosis, add 15 to bicarb. Okay. 34 plus 15 is 49. Expected CO2 is 49, but here in this case CO2 is 55. Means there is additional respiratory acidosis. A COPD patient who is on diuretics, COPD is the cause for respiratory acidosis. COPD, the acute exacerbation, is the cause for respiratory acidosis. Diuretic, the cause for metabolic alkalosis. So PCO2 is high means respiratory acidosis. High bicarb means metabolic alkalosis. So second, the PCO2 high bicarb means respiratory acidosis and metabolic alkalosis. If anion gap is high, there will be additional elevated anion gap metabolic acidosis. Low PCO2, low bicarb, respiratory alkalosis, anion gap normal. So respiratory alkalosis plus normal gap metabolic acidosis. So low PCO2, low bicarb, respiratory alkalosis and high anion gap. So elevated gap metabolic acidosis. So last one is normal PCO2, normal bicarb. In that case, if there is high anion gap, that indicates elevated gap metabolic acidosis. We should look for other additional disorders also. So delta ratio is a calculation that compares the increase in the anion gap to the decrease in bicarb. It is the ratio of increase in anion gap to decrease in bicarb. We expect 1:1. We expect that ratio to be 1. If anion gap increases from 12 to 20, if there is 8 increase, we expect 8 decrease in bicarb. Okay. So here delta anion gap is measured anion gap minus normal anion gap. That is called delta anion gap. Delta bicarb is normal bicarb minus measured bicarb. That is delta bicarb. So delta anion gap by delta bicarb is delta ratio. That should be 1. Okay. If you expect some bicarb level, if that bicarb is lower than expected range, there must be additional normal gap metabolic acidosis. If you expect some bicarb level, if that bicarb is higher than expected range, there must be additional metabolic alkalosis. We will look into some case examples. This is a normal acid base status. What is the anion gap? 140 minus 104 plus 24, 128. 140 minus 128. This is 12 anion gap. 12 anion gap is normal. Bicarb is 24. So it is a normal acid base status. Okay. Coming to the second one, what is the anion gap? 140 minus 104 plus 12. Okay. 104 plus 12 is 116. 140 minus 116, 24. Okay. Here anion gap is 24. There is increase in unmeasured anions. So anion gap increases. So anion gap is 24. It means from normal 12, it is increased to 24. Anion gap increases from 12 to 24. How much bicarb we expect? 24 minus 12. And in a pure case of high anion gap metabolic acidosis, if there is no additional disorder, additional process, we expect similar decrease in bicarb. So here there is 12 increase in anion gap and 12 decrease in bicarb. How much is the delta anion gap? Delta anion gap is the measured anion gap minus normal anion gap. Means 24 minus 12. That is 12. Delta bicarb is normal bicarb minus measured bicarb. Again 24 minus 12. Okay. 12 by 12 is 1. So this is a case of elevated gap metabolic acidosis with delta ratio of 1. Delta ratio usually it will be 1 in diabetic ketoacidosis. In diabetic ketoacidosis, if there is no renal failure, if renal function is normal, we expect 1 delta ratio in diabetic ketoacidosis. So if there is no renal failure and if delta ratio is more than 2, we should look for some other additional disorder in a case of diabetic ketoacidosis. To the last one, third one, what is the anion gap? 140 minus 98 plus 18. Sodium minus chloride plus bicarb. How much is anion gap? 24. Bicarb is 18. So what is the delta anion gap? 24 minus 12. Delta anion gap is 24 minus 12. That is 12. What is the delta bicarb? Normal bicarb minus measured bicarb. Normal bicarb is 24 minus measured bicarb. Here it is 18. 24 minus 18 is 6. So delta anion gap is 12. Delta bicarb is 6. So what is the delta ratio? Delta anion gap by delta bicarb is 12 by 6. Here the delta ratio is 2. We expect 1, but here delta ratio is 2, more than expected. That indicates additional underlying metabolic alkalosis. You want some clarification in regarding metabolic alkalosis? So if anion gap is 24, how much bicarb we expect? From 12 it increases to 24. Okay. Again in the bicarb we expect 12 decrease from 24 to 12. But here bicarb is 18. It means there is additional metabolic alkalosis. The first is normal acid base status. The second one is elevated gap metabolic status. We will come to third one. In the third one, anion gap is 24, but bicarb is 6. With anion gap of 24, how much bicarb we expect? Again 12. We expect 12 bicarb, but here bicarb is 6. Means there is additional bicarb loss. There is additional mechanism for bicarb loss. So that means elevated gap acidosis plus normal gap acidosis is a mixed disorder. So step 1, 7.17 metabolic acidosis. Acidosis metabolic or respiratory? Metabolic. So bicarb is low, but PCO2 is high. It is metabolic or respiratory? And there is one simple clue is ROME, R-O-M-E. There is respiratory acidosis. If pH decreases, PCO2 increases. If pH decreases and PCO2 increases, that indicates respiratory acidosis. So predominantly the respiratory acidosis case. So in respiratory acidosis, how much compensation we expect? So for metabolic acidosis and metabolic alkalosis, respiratory compensation is bicarb plus 15. For acute respiratory acidosis, 1 for 10. You remember 1 for 10. Okay. For acute respiratory acidosis, for 10 increase in carbon dioxide, PCO2, there will be 1 increase in bicarb. That is for acute respiratory acidosis. For acute respiratory alkalosis, you remember 2 for 10. For respiratory acidosis, 1 for 10. For respiratory alkalosis, for acute respiratory alkalosis, 2 for 10. For 10 decrease in carbon dioxide, there will be 2 decrease in bicarb. For chronic cases, for chronic respiratory acidosis and for chronic respiratory alkalosis, there will be decrease from 3 to 5, around 4. Okay. So acute respiratory acidosis, 1 for 10. Acute respiratory alkalosis, 2 for 10. For chronic respiratory acidosis and respiratory alkalosis, from 3 to 5, around 4. So here it is, because he was last seen leaving a party 6 hours prior. Okay. The respiratory acidosis, how much bicarb we expect? From carbon dioxide increases from 40 to 65. So there is 25 increase. Means we expect 2.5 increase. From 24, bicarb should increase to 26.5. Okay, we expect bicarb to be 26.5, but here bicarb is 22. So there is additional metabolic acidosis. Calculate anion gap. Here anion gap is 16, but here albumin is 1.6. So we have to adjust anion gap with albumin level. Again, elevated gap, metabolic acidosis. Then fifth step is calculate delta ratio. What is the delta anion gap? Adjusted anion gap is 22. 22 minus 12. Measured anion gap minus normal anion gap is delta anion gap. Delta anion gap is the difference in anion gap levels. Measured anion gap minus normal anion gap. Here measured anion gap, that adjusted anion gap is 22. Normal anion gap is 12. 22 minus 12, the delta anion gap is 10. But the delta bicarb, normal bicarb minus measured bicarb. Normal bicarb is 24, measured bicarb is 22. So bicarb difference is 2. 10 by 2 is 5. Normal how much delta ratio expect? Around 1. Here it is almost 5 times, more than 5. So there is additional metabolic alkalosis process. Okay. So there is elevated gap metabolic acidosis with respiratory acidosis and additional metabolic alkalosis. The triple acid based disorder. The patient is alcoholic, found unconscious. Alcoholic unconscious. That could be the reason for respiratory acidosis. And so with vomitings could be the cause for metabolic alkalosis. Okay. Vomiting means HCl loss. The chloride loss, whenever there is chloride loss, that will be compensated by bicarb accumulation. Okay. Whenever there is bicarb loss, that will be compensated by chloride accumulation, chloride bicarb exchange mechanism. Pregnant women, non-stop vomiting. Here pH is 7.41, PaCO2 42, HCO3 26. Almost all are near normal levels. Normal pH is 7.4, it is 7.41. PaCO2, normal PaCO2 is 40, it is just 42. Bicarb is 24, it is just 26, almost near normal levels. But the anion gap 146 minus 92 plus 26. 118 kada, 146 minus 118. 28, high anion gap. So even though pH, PaCO2 and bicarb are in the near normal values, we should look for anion gap. The same patient. So there is high anion gap, metabolic acidosis. Here it is 7.39, PaCO2 22, bicarb 13. The case of metabolic acidosis. Okay. Metabolic acidosis. And what is the anion gap? 139 minus 88 plus 13. High anion gap. 7.29 acidosis, metabolic acidosis. How much carbon dioxide compensation expect, respiratory compensation expect? 14 plus 15. Bicarb plus 15. 14 plus 15 means 29. And appropriate compensation. Again anion gap is elevated. Elevated gap, metabolic acidosis. And delta ratio is less than 1. That indicates additional normal gap metabolic acidosis. Low CO2. Low CO2 indicates the respiratory alkalosis part and metabolic acidosis. Anion gap is high, elevated gap metabolic acidosis with respiratory alkalosis, but delta ratio is 2.2. So there is additional metabolic alkalosis. So important causes for elevated gap anionic metabolic acidosis are various mnemonics, mud piles or cat mud piles, gold mark, but easiest way to remember is CULT, KULT. So if anion gap is elevated, we should look for acidosis. If there is acidosis, it means high anion gap acidosis, then we should look for all the 4 causes. Look for lactate for lactic acidosis, ketones for ketoacidosis. and I look for renal failure, I look for any ingestion of toxins or drugs. So, if anion gap is normal anion gap metabolic acidosis, important mechanisms are loss of bicarb and accumulation of hydrogen ions. The accumulation of hydrogen ions in the tubules or loss of bicarb, either GI loss or renal loss. GI loss is diarrhea, renal loss is renal tubular acidosis. So, in the renal tubular acidosis, the proximal renal tubular acidosis, there will be bicarb loss. In the distal renal tubular acidosis, hydrogen ion accumulation, potassium loss and hydrogen ion accumulation. In the type 4, aldosterone deficiency, mineralocorticoid receptor will be resistance, again hydrogen ion accumulation. So, all these conditions they cause normal gap metabolic acidosis. So, in the renal failure, initially there will be normal gap metabolic acidosis. In the later stages, there will be high anion gap metabolic acidosis. In the later stage, there will be accumulation of anions, non-measurable anions, like phosphate, sulfate. There will be more uremic toxins are accumulated. So, in metabolic acidosis, look for anion gap. We look for compensation first, then look for anion gap, then look for delta ratio to identify the mixed acid base disorders, to identify triple acid base disorders.